Today we're celebrating World Asthma Day, and with me I have 3 members of KMTC who will spend some time discussing about asthma. So I would like to start by asking them to introduce themselves. So I will start on my extreme left. Please go ahead.
Thank you. I am Dr. Kennedy Rateng, Head of Health Services, and also a lecturer in the Department of Clinical Medicine at KMTC.
My name is Dr. Anne Claire Mwendwa. I am a lecturer in the Department of Clinical Medicine, and I'm a pediatrician by training. Thank you.
I am Josephine Gibinji, a nurse by profession, working in the Health Services Department, Kenya Medical Training College.
And I am Dr. Agaki Gisheru, anesthesiologist and e-learning coordinator, and I shall be the moderator for this conversation around asthma. So, of course, the best place to start is defining what asthma is. So I would maybe ask Dr. Rateng, what is asthma?
Thank you, Dr. Gisheru. Asthma is one of, I would say, a common disease or a common condition in which the person's airway is inflamed and is then narrowed and swollen with increased mucus production, and all this will make this person to have difficulty in breathing. It's usually the inflammation is triggered by allergens or things that the body reacts to. Thank you.
Thank you, Dr. Rateng, for that definition of asthma. Maybe Dr. Mwendwa, would you like to add anything else about what asthma is?
Thank you. Asthma is a chronic condition, meaning that it stays with the patient for a long time. And as my colleague has said, it's due to irritation of the airways, meaning that the patient is not able to breathe out and in well, and therefore presents with the various symptoms, as we shall allude a bit later. Thank you.
All right, thank you. So chronic meaning that it stays for a long time and you have it for an extended period of time.
Yes.
Wow, okay. So why then should clinicians be concerned about it? Maybe Nurse Josephine, you could tell us what are some things that you've seen in your nursing practice that you would say people should be concerned about asthma?
Thank you for that question. Why people should be concerned about asthma is because it has triggers, and there's empowerment in knowing what are my triggers, because then it reduces the number of asthmatic attacks and improves the quality of life. So in asthma, knowledge is power, and it can be, life can be improved by knowing these are my triggers. Thus, the major concern is education and empowering of the patients.
Okay, so letting people know what things they can run into and how to avoid is one of the things that we should take into consideration. Yeah, yeah. Thank you, Dr. Mwendwa. You're a pediatrician, so from a pediatrician point of view, why should we be concerned?
Okay, the children that normally we see with asthma, one of the major concerns that we have is the quality of life. And for the children, how do we measure the quality of life? We look at the missed school days, the emergency hospital visits, as well as the hospitalizations. And when we look at the hospitalizations especially, that becomes such a heavy health burden to the family and even to the nation as a whole. Thank you.
And Dr. Rateng, you deal with our student population here, as well as adults. Any other areas of concern?
Yeah, just like my colleague has said, really, there's economic burden to asthma that is both to the health institutions and to the community. Because you see, when one has these attacks, they are not able to breathe. That means they are not able to work. They miss work, and that's an issue. And also just the cost of treatment. We have realized that it's a chronic disease. So the cost aspect of it is an issue of concern. Then there's also complications that we see in adults when they stay with asthma for long, not well controlled. They get into things like chronic obstructive pulmonary disease, which is, I would say, not a very easy disease to handle. Thank you.
So we are missing work, we are missing school, our quality of life is not so great, we are missing knowledge that can help us be able to deal with asthma. So there are many reasons why we should actually take time to talk about asthma and to think about it. So thank you for that. We've said children, we've said adults. What are the risk factors of developing asthma? And maybe we can start definitely with children and then work our way to adults.
Okay, thank you for that. We look at risk factors in two major ways. The first thing is a positive family history. And we always look back at, the close relatives, and especially first-degree relatives, to see whether they have had a history of asthma. In children, they are a special category because on top of the family history, we look at other two conditions that are associated with allergies, and these two conditions is eczema, which is a skin rash that develops especially in the younger babies. And secondly, we look at a condition known as allergic rhinitis, whereby the child keeps presenting with what seems like a common cold that never seems to go away. And therefore, those two conditions, coupled with a positive family history, for us as pediatricians, are the things that point to us that this child is one that we need to look at closely as a possible candidate for asthma. Thank you.
And in the adult population, what would be some things that can make you develop?
Some of the risk factors we see in adults are things like cigarette smoking. Yes, cigarette smoking is a key risk factor. Then other things like occupational exposure or hazards, those people who are working in areas with a lot of fumes, cement factory, for example. Some people who work in chemical industries with chemicals with strong smells. We have also seen people who are overweight as having a risk of developing asthma. And as my colleague has said, a history of a relative with asthma or any other allergic conditions like as mentioned, dermatitis, rhinitis, allergic, those are people who are at risk, even in adults, of developing asthma. Thank you.
Okay, so thank you. It seems like there's the aspect of the family, if there is a history, and then there's also the environmental aspect and other disease conditions that someone might have within them that predisposes them. Maybe we can go back to the issue on environmental. What would be some things, Dr. Oteng, that you could say would be a trigger that will cause somebody who's asthmatic to now have like an attack?
Yes, triggers are many, and these are variable depending on different patients, that is. We have triggers like dust is a major trigger. Our environment is full of dust. Then we have things like smoke or fumes. These can be fumes even from the firewood that we use in our homes, in enclosed buildings. We have triggers like chemicals I've mentioned, strong perfumes to some people. When they get a smell of a strong perfume, that can be a trigger. Exercise. There are some people that when they get into an exercise, an activity, this can easily trigger their asthmatic attack. Thank you.
Are they different in children? Are they the same?
We see a bit of an overlap in terms of the triggers, but in children, commonly, the first factor that we see is upper respiratory tract infections, which is a common cold. And children, we say normally per year, we see about 80 to 90% of the time they'll always have a cold. So upper respiratory tract infections do trigger asthmatic attacks. The other second factor is psychosocial stressors, which again are uprising in children, and that also does trigger attacks. I'll show you a bit of pictures that are relevant for us to be able to remember. This particular one shows the house dust mite, and this particular mite exists in the areas in the house that carry a lot of dust. And I'll give you examples. One is the mattresses where our children and all of us basically do sleep. And then the second one is the carpets. And then stuffed animals, which our children love very much, and even our sofas in the house that are made of upholstery. So these are areas where we are likely to have the house dust mite. My colleague has talked about smoking. For children, we are mostly concerned about the indoor smoking. So a parent who smokes within the house is really a major factor that can trigger the asthmatic attacks. Another thing that they react to is cockroach byproducts, that is their waste products, their urine and all. And therefore, we need to, again, remember that cockroaches is a major risk factor for children. An emphasis on indoor use of fuels that emit a lot of smoke, such as charcoal, firewood. When we use them inside the house, again, that has been shown to increase the risk of asthmatic attacks. Our children love pets, and therefore the dogs, the cats, and specifically this is about the shedding of the hairs and even their saliva, and that has been shown again to trigger asthmatic attacks. On the outside, we talk about air pollution, and remember we are constantly having many people move into the town areas, so industrialization is one of them, and even the fact that when many people move to the town areas, the housing units become smaller and smaller, ventilation is an issue, and therefore that increases the indoor air, the quality of the air within the house. The second factor that is shown here is the fumes from the cars. Again, as more and more people move to the towns and everyone wants a car, and therefore the car fumes have also been shown. As part of the environment is also the seasonal, the pollen grains from the flowers and the trees as they bloom, and therefore we need also always to take care of the environment where our children stay. So at the end of it all, what we are talking about here is exposure to certain allergens within the home and even out of the home. And what we are talking about is the quality of the air where our children stay, among other factors. Thank you.
There's a lot that one needs to check and ensure so that they don't get triggers and they don't get then an asthmatic attack. So suppose then the child or the adult develops asthma, or starts to then have what we call an attack. What does it look like? How can a parent know that their child has an attack? Or how can a young person know that now I have an attack and I need to do something about it? What would they present with?
Okay. For children, thank you for that. For children, commonly what we see is recurrences of the cough episodes. And this cough tends to be mostly in the night or an early morning cough. Secondly, this cough is accompanied by wheezing, which is a musical sound that we hear from the upper airway as they breathe, especially out. And then also, some of the children will complain of tightness in the chest, and this is usually for the older children who can be able to express themselves. Other things that we have seen is a cough that gets worse with exercises, and then all that is accompanied by poor sleep And therefore, the older children are not able to have very good quality days because of daytime fatigue. Yeah, thank you.
Okay, and in the adult population?
Yes, thank you. The presentation is almost the same. Adults will come with a recurrent history of cough, just like is seen in children. They'll have shortness of breath or difficulty in breathing. They'll also present with a wheeze. This is the musical sound, as my colleague has said, and it's more louder when one is breathing out. And they can come also with the inability to talk, to complete a sentence because they are struggling to breathe.
And it's in severe forms. Is there a difference, something that people need to now know that this needs very urgent attention?
Thank you.
Yeah.
Yes. Asthma actually can be graded in terms of severity. We can have a mild attack. We can have what generally we can say moderate, then severe attack or severe persistent asthma. So the mild one is what we have said. This somebody is just having a cough, a difficulty in breathing. He has a wheeze, but he's still able to talk, explain that's if he's an adult. But as the person gets into the moderate ones, the symptoms become severer. And severity, actually, the best way to explain it is to talk of the number of attacks one is getting, like per day or per week. Like when we talk of moderate or asthma, this is somebody who is now getting more than 2 episodes of attack within a week. Then perhaps with one occurring at night, that's a moderate one. When it comes to severe or persistent, the attacks are now frequent, even frequently occurring at night, interfering with sleep. So the severe form, the cough definitely severe, and the difficulty in breathing can become that severe that some changes can be seen in the body. That is, they can be turning even blue because they are not getting enough oxygen within their body system. They are not able to talk, as I've said, because they want to breathe. They are struggling for air. Yes, and that's quite a severe presentation that we need to do something immediately.
Mm-hmm. And in children, how can you tell that this is very severe now?
Okay, in children, the presentation is quite similar, but 2 things stand out. And that is the inability to talk complete sentences in those children who are already able to communicate. And we use the cutoff of 2 words. At times they just use 2-word sentences, and we know that this asthmatic attack is quite severe. Other times they might lose consciousness, and other times when we take, for example, the heart rate is very fast, and at times we use even the cut of 200 beats per minute in children who are less than 3 years old. So those 2 are the main factors that we use to assess severity of an attack.
And so because asthma is affecting the lungs and someone's breathing, therefore if you're having difficulty in breathing, then also talking becomes a challenge, and this person will be struggling. So it is important to bring that out so that people can see that there's attention that is needed. So now we're moving to, we know what asthma is, and we know what the triggers are, and we know what it looks like. How do we then treat patients who present with asthma? And I think we'll do it the same way. We can start with the pediatric population, and then we go on to the adults.
We always will look at the severity, and therefore, first of all, we use the history and the examination findings when the patient comes to us. And then we classify the patient into either mild, moderate, or severe. And normally, for the basic medications that we use are the inhalers. And the inhalers is the mainstay of management. And there are 2 classes of inhalers. there's the rapid relief inhalers, which act to now widen the narrowed airway. And when you give that medication, then the patient gets the rapid relief. My colleague had mentioned the constant irritation that happens in the airway. So for this, we use the second type of inhalers, which we call the corticosteroids. And these ones are also given as, inhalers. And therefore, these ones reduce the inflammation, and these ones are used on a long-term basis. So I'll just show you the example of an inhaler that commonly is used both for adults and children. And for children, for us to be able to deliver this medication adequately where it is required, we need this other gadget, which is known as a spacer. This spacer is usually bought from the pharmacy. As the patient gets the inhaler, you also get a spacer for the child. And the delivery depends on the age of the child. So for the very young ones, this particular portion will have a mask to help you administer the medication. But for the older ones, older than 2 years, they are able to put their mouth here and you're able to deliver the medication. Now, probably I would also show you where the inhaler is inserted, and therefore just a short way of, assembling everything. And this bit of, education of the patient, this happens as they buy of the medication so that they know how to use them. When the child comes in a severe attack, there are other ways in which we administer the medication. Of course, the first line is still to use the inhalers, but in more frequent doses, and we monitor the child and see the response. When then the child is too sick, or the very young ones for which you cannot use this gadget, is what is known as a nebulizer. And later on, the demonstration on how the nebulizer is used will be done by our sister, Josephine. Thank you.
Great, thank you for that. Are there other things in adults that you combine?
Yes, thank you. Just as my colleague has said, the treatment in children and adults are not that different. What I would like to emphasize on is that health education is very, very key. Once a clinician has made a diagnosis of asthma, which my colleague also has said, that is basically based on the history and the examination, that's a physical examination. This is a disease that we don't need to do many tests or investigations, to make a diagnosis. Once that diagnosis is made, the patient needs to know that he's asthmatic, and he has to be taught about the triggers, and again to know how to use his medicine well. Because so long as the triggers are not well taken care of, the attacks will keep on occurring. As long as one is not using the medicine properly, he'll get into attack. So we emphasize on that so that they learn to know how to manage their own disease. Then we use the same medicine. We have the quick relief medicine, because that's what my colleague has said, the short-acting beta agonist. The commonest one that is so much we know about is salbutamol. The trade name of one that has been with us for a long time is Ventolin. Yes, it is there as an inhaler, but I know there are also tablets there for the same medicine. What we are encouraging in others is the use of inhaler, because this is a good way of administering medicine to relieve these patients quickly and better with fewer side effects of the medicine. There's also some short-acting. These are the anticholinergic. They are there in the markets. What they do, they make the airway wider. The airway is wider so that one can breathe better for quick relief. My colleague has mentioned the steroids, and again we emphasize that the best way to administer steroids for asthmatic patients in adult is to use inhaled corticosteroids. In short form, what we refer to as ICOS. In this way, they get few side effects of this medicine, if any, as opposed to when they take them as in oral form. But situations might demand, in severe asthma, sometimes patients we have to give systemic steroids, either the oral or even injectable. But these are usually given for a short period of time. Thank you.
So you mentioned nebulizer and nebulization, and I want us now to just take some time and see a demonstration on how to do nebulization, and Josephine Githinji will do the demonstration for us.
Welcome to this demo. I am Nurse Josephine. I will be taking you through a demonstration on the nebulization process. Nebulization is for patients who are asthmatic, also patients with chronic obstructive pulmonary disease, COPD. Why nebulize? Nebulization, this gadget is meant to deliver medication deep into the lung tissue. For some reason, the inhaler may not be able to deliver medication deep into the lung tissue, and that is where the nebulizer comes in, or when the patient is severely sick. To start with, the nebulizer has a few parts. There is the air compressor. There is the air compressor sometimes can be battery operated, meaning that you can carry it even to the outdoors. Sometimes it is electric, and there's the tubing that connects the air compressor to the medicine cup. The medicine cup is where you fill the medication as per the prescription. There is the mask that delivers the medication to the patient. Other gadgets that can be used to deliver medication are maybe a mouthpiece. Also, there's this gadget that can deliver the medication through the nostrils. It's called a nosepiece. So to begin with, you find by finding a hard surface that is leveled, it is easier to work with it. Then clean your hands. As for me, I'm just going to sanitize. Now, we start with filling the prescribed medication into the medicine cup. So you fill the medicine cup with medication, connect the air compressor to a source of power, then connect one end of the plastic tubing to the air compressor. Then one end of the tubing, picking the medicine cup carefully so as not to spill the medication, connect with the air compressor. And then depending on if this medication is supposed to be given to a child or to an adult, then I'll use the mask. Maybe for the child, you connect it. And mask the child. If using the mask, make sure that the mask covers both the mouth and the nose. If using the mouthpiece, make sure that the tongue goes under the mouthpiece and the lips are tightly sealed around the mouthpiece to avoid spillage of the drug into the surrounding air. So in all this, the patient is advised to stay upright so as to avoid the spillage of the medicine from the medicine cap. So the patient stays upright and the gadget is put on. Press the on button. Then the medication comes out in form of a mist, and in case of anything, in case for any reason that you need to stop the process of nebulization, what you do is you switch off the gadget to avoid the medication going into the surrounding air. Sometimes the patient may need to cough, may need to take a break to vomit, or for any other reason. Now, for how long do you nebulize? You nebulize until the prescribed medication is over. How do you know that it is over? You know it is over when there is no more mist coming from the mask, or there's a splattering sound coming from the gadget. What you do when there's no more mist, gently tap on the medicine cap. This brings any medication that was on the walls of the cap to the bottom. And so most of the time you'll find that the mist starts coming out again. So continue giving the medication until there's no more mist. When that is done, switch off the gadget and disassemble the instruments and clean them in running water, and put them on a towel so that they dry and they can be stored in a plastic container. It is also important to schedule a weekly cleaning whereby these gadgets are placed in hot water for 10 minutes just to make sure that they are good for use. Thank you.
Thank you, Josephine, for that demonstration. We have learned really how to do nebulization, and I think now people are not so afraid to bring their patients or family members who have got asthma to come for that nebulization. We do appreciate the demo. So you also said, and all of you have said, prevention is key. What would be some of the measures that we can take? One, as parents of children who have asthma, or even as young people who have asthma. What would you say, Dr. Mwendwa?
As my colleague said earlier, knowledge is power. So education of the parent, and we are educating them especially on the triggers that I had mentioned earlier that are found where this child is living. I will give you examples of some of the ways in which we encourage that in the home we try and have better air. For the house dust mite, we said that this is found in, the beddings, the mattresses, the toys that the children play with that are stuffed. So how do we eliminate or reduce the population of the house dust mites? One of the things that has been recommended is encasing the mattresses in a plastic cover, and one can buy off the mattresses the normal way we buy, but you take another step of having them encased, and therefore we get rid of the exposures to the children in the night. For the beddings, it's recommended that we wash the beddings every week, and the water has to be very hot in order that we are able to kill again this mite. For the stuffed animals, the same way, we wash them every week. And then the carpets, it's encouraged that as much as possible, we get rid of the carpets in the homes where there's an asthmatic child, or you use the smaller rugs that are easily washable. The other element is to discourage indoor smoking. As we had said earlier, this is a major trigger to asthmatic patients, and also to encourage use of the clean fuels. Clean fuels in our environment will be gas mostly, And therefore, how do we encourage this? We empower our people to have better earning capacities to be able to, first of all, have the knowledge and also to be able to buy the cleaner fuels. Cockroaches. We all see them in our homes, but how do we discourage, the populations getting higher? We get rid of remnants of food and water in the night as we go to sleep. We, take away all the remnants and keep them away in well-sealed containers. And then the other thing was the indoor pets. Get rid of indoor pets, and especially in the child's room. We all love them, but the hairs from these animals and also the saliva does trigger asthma. Air pollution. There's a lot that can be done about this, improving the quality of housing, and so much else that goes into the environment. Psychosocial stressors. There's a lot going on about mental health problems. These too do affect children, so we need to look deeper into the mental health issues of our children. Upper respiratory tract infections, as much as possible, we reduce again our children coming down with that. So in a nutshell, those are the common preventive measures in children. Thank you.
Thank you. And Dr. Rateng, in the adult population?
Yes, thank you. Almost the same, but as I mentioned that occupation is very important to note, and some of this we pick during when we take the history as we are diagnosing asthma. We can pick a trigger based on the occupation. So a situation can be that somebody has to change his occupation. If you're working in a dusty environment, perhaps you can move to an apartment with lesser dust or with no dust. If you are working in a company that is dealing with a substance that is triggering your attack, then the advice would be to change your occupation. Other than that, I think others are the same. The pollution in the environment is generally a trigger to many people. So those are things that we need to take care of. Smoking is a no-no. I know there's to the children, we talk of smoking in an enclosed environment. Viewing children as a second-hand smokers, or passive smokers. But adults should stop smoking and stop it in an area that you are endangering others. Thank you.
Patient education is key, helping them understand what asthma is, how they know that they're having an attack, how they can be treated, how serious it is for them to take their medication religiously, and then also understanding what it is that makes them have attacks. And you have really emphasized and given us some tips on things that we need to be aware of. Today, as we celebrate World Asthma Day, the theme is understanding or uncovering misconceptions around asthma. And I want to maybe start off by asking Nurse Josephine, because she is keen on patient education and she'll be the first person who comes in contact with an asthmatic patient. What are some misconceptions that you have had, that you've had to deal with?
Thank you for that. The most common misconception is that asthmatics should not exercise, should not participate in physical exercise. As we have seen in this discussion, the triggers to an asthmatic attack are very many, and exercise can be one of them. But otherwise, a child should be encouraged to participate in school games, and an adult should participate in physical exercise unless they observe that it actually triggers an attack for them, because one person's attack is not the other. Yes, so that's the most common misconception, that asthmatic patients should not participate in physical exercise.
Mm-hmm, mm-hmm. Yeah. And Dr. Mwandwa had said about one of the things that happens is that quality of life, we should be concerned because quality of life is interfered with. And so you have then people thinking that their whole life has changed and they can't even exercise as a misconception. So that's a good point about that, having conversation with their physician about what they can, or pediatrician, what they can do to have physical exercise. That's great. And misconceptions that you've come across from parents, relatives, children about asthma?
People believe that asthma is a childhood illness and therefore the children will outgrow it as they get older. That is not true, and we should put it out there that once diagnosed to be asthmatic, you will most likely live with it the rest of your life. So children do not outgrow asthma. The other misconception is that asthma is infectious. Asthma is not an infection, although we are saying that upper respiratory tract infections will trigger the asthmatic attacks, but asthma itself is not an infection. The third one that is also common is that the asthma medications are addictive, and therefore people fear being put on the inhalers. None of the types of inhalers we have talked about is actually addictive, and therefore even if one needs to go on, especially the corticosteroids for most of their life, then we do not find dependence developing with this. The last one I want to mention is that at times the children are labeled as, the condition being just in the head, and therefore even when they come with an asthmatic attack, some people think that they are playing, and at times we have lost patients because of people not taking it seriously.
Wow. And any other misconceptions that you've seen? You deal a lot with young people here in our institution. Yeah.
The major misconception is that asthma is a disease that you are born with and you can't get it as an adult. So sometimes to accept others to accept that they are asthmatic, they don't accept it. They will deny, they say, no, I'm not asthmatic, I was not born with asthma. So people should know that asthma is a disease that you can develop it at any age. As much as you have said that is commonly seen earlier in children, but as an adult you can also develop asthma. The other misconception is that, I think my colleague has said, is that inhalers are for only severe form of disease, and many adults will resist or will not want. They'll tell you, no, give me tablets to swallow because mine is not serious. I would want to tell people out there, the public, that the best medicine for asthma are the inhalers. They have fewer side effects, and their effects in managing asthma are generally better. Thank you.
The viewers who are watching this have probably had some of those misconceptions. And the aim of this panel and this conversation is so that then they can start to think about asthmatics that are around them, some of the misconceptions that affect them, and some of the ways that they can understand the disease better. So I now want to ask maybe each one of you to maybe give us an idea. How can we raise awareness or create awareness about asthma in our environments, in our communities, in our families, in our workspaces? What can we do as we think about asthma as a disease? And I think I can start my immediate left.
What we can do as medics for the community, one is to educate them that really asthma, there's a lot of stigma that comes with it. And so when the community is aware that asthma is not a really, you're not cursed, you're not, then they accept when they experience the symptoms, and all you need to do is go to the hospital, and if this will be sorted, avoid the allergens, then the community will not hide these asthmatic patients.
So medical personnel should be in the forefront in raising awareness.
Yes.
Yeah, okay,
Yes.
all right. Dr. Mwendwa?
Okay. One of the ways that we can exploit is really the news media, social media. There's a lot out there that we need to put out the facts about asthma. That asthma is real, asthma is treatable, asthma is manageable. So social media is one of the avenues that will carry the day. On top of what my colleague has said, also health talks that can be delivered in schools, where we know the majority of our children will really be captured, and we can even teach them on how to use the gadgets well. And also the exploitation of barazas, where again we are able to catch the adults. And also forming support groups that can be started, yes, by the parents, but also the communities can be able to come alongside, and we have more people participating. The last but not the least is for us as educators. How do we train our clinicians to have that high level of being able to diagnose asthma and not to fear to make the diagnosis? Because at times we fear to label patients asthmatic. And therefore for us as clinicians is training well, so that now the people that we channel out are able to pick out the patients and be able to manage them well. Thank you.
Dr. Ateng, anything else?
Yes, just to emphasize that awareness is very key in a disease like asthma. Create awareness to the public to know that this is a disease that is real, just as my colleague has said, is manageable, is a disease that you can live with without any really not being able to perform many of the functions that we do as human beings. So people should be encouraged to come. I know something just to say during this time that we have this pandemic, COVID-19, and you realize this disease also affects majorly the respiratory system. Many of our asthmatic patients are out there, they don't want to come for their clinics, fear being labeled asthmatic. We would encourage asthmatics to attend the clinics as usual. Studies out there, none has shown that if you have asthma, you are at risk of getting COVID easily than any other person. The studies also has not shown that asthmatic are getting a severe form of COVID than the general population. But generally, we should just know that yes, COVID is there and asthma is also there. So please, public, we would encourage you, those who are asthmatic, keep on coming for your clinics and take your medication. The other thing that perhaps when I'm around there just to mention, we have mentioned here that steroids are used in treating asthma. And I know the public is aware that the same steroid is what we are using in treating COVID. So a question, the few patients have come across, some ask, now do we stop using our steroid for managing asthma, or what do we do? I would encourage the asthmatic patients to continue using their inhaled corticosteroid. They should not stop. Thank you.
Wow, thank you, even for bringing up the aspect of COVID, because I think it still affects your lungs, and breathing is still an issue. So, and it is a difficult subject to discuss, but thank you for bringing that point. Great, so I think we have covered quite a bit of ground on asthma. We've discussed what asthma is, we've discussed the people who are at risk of developing asthma, we've discussed the triggers. What are the things that are around you that can make you have a frequent attack? We've also said, how do you know when you're having an attack, and how can you tell when your attack is fairly severe? And we've also now talked about some misconceptions. Perhaps now we can, because we've come to the final bit, is there anything that you've remembered that you would want to say or emphasize just as at the end, so that then we can be able to wrap it up? Any parting shots or parting words about asthma that you'd like to tell our listeners and viewers today? And I'll leave it open for anybody to say.
Mine, from a pediatrician's point of view, is that in as much as we have said asthma is not curable, asthma is controllable. And one can lead the best of life and to the best capacity when asthma is well controlled. To our children, we want them to exploit all avenues of what there is to exploit in their lives and therefore gain maximum out of their lives. Thank you.
Asthma is real, it's a common disease, but I would say here that after listening to the discussion around here, the patient, that person with asthma, is the main doctor of his disease. Because once you know the triggers, then you avoid, you are free from the attacks and you are well. So please get to know the triggers very well and avoid them, then you live your life in a normal way. Thank you.
Asthma is one disease that once you have developed you develop observatory skills on what triggers your attacks, then you can be able to control it. And so that part of understanding your triggers is very important. The other thing is because it affects your breathing, and breathing is life, then when there's an attack, then act fast and you will save life.
So thank you very much, panelists. Thank you for your insight. Thank you, Nurse Josephine, for the demonstration. And thank you, our viewers, for spending the time to listen to this conversation. I hope that it was useful to you and that it has created some level of knowledge for you, either as an asthmatic or as a person who knows an asthmatic, or even as just a person who is interested in the conversation, that you will be able to now know some of the challenges that asthmatics face, and perhaps you can now engage them further in conversations around the disease because you do know something about it. So thank you again for your time.